Lecture is going to be on cirrhosis of the liver. This is the end stage of liver disease. It is characterized by extensive degeneration and destruction of the liver cells. This results in the replacement of liver tissue by fibrous or scar tissue and regenerative nodules that occur from the liver's attempt to repair itself. The development usually happens over decades of chronic liver disease. Biliary cirrhosis, which is PBC, is a chronic disease of the small bile ducts of the liver. There is a T cell mediated attack of the small bile duct cells. This causes a loss of bile ducts and blockage of bile flow. Over time, this leads to liver fibrosis and cirrhosis. PSC is characterized by chronic inflammation, fibrosis, and narrowing of the medium and large bile ducts both inside and outside the liver. Cardiac cirrhosis really comes from a result from long-standing severe right-sided heart failure. There are several risk factors for cirrhosis. However, the most common cause here in the United States is chronic hepatitis C. So, kind of looking at our like baby boomers, you've seen more advertisements and things like that about getting screened for hepatitis C and alcohol induced liver disease. Those are the two main causes. There are other causes, such as people who go through extreme dieting, malabsorption, like if they're not able to absorb nutrients, things like that, if they have any malabsorption problems. And of course, there's obesity. There's environmental factors, and there's also a genetic predisposition to having cirrhosis. When you start with your assessment, you of course want to ask about past health history, any previous history of hepatitis, any chronic biliary obstruction and infections, and of course if they have any type of heart failure, like severe right-sided heart failure. I'd also ask about medications that they take currently, over the counter, any additional supplements, and of course, any type of prescribed medications. I'd ask about any type of usage of anticoagulants or aspirin, NSAIDs, acetaminophen. I'd ask about alcohol usage, like how often do they drink, how long, and ask them if they've had, previous history of alcohol abuse or anything. Do they have a lot of weakness or fatigue? Have they lost weight, unexplained weight loss? Um, do they have any, like a lot of gas when they consume food? Any type of nausea, vomiting, and if they've had any, their gums have bled or anything like that. So in the early times, there's generally very few symptoms in this early stage. Um, the liver may seem enlarged, and that might be the first indication that there's a problem. We, of course, can look at some different blood tests. We can look at uh, liver function tests to see if they're normal or abnormal. And then some of our late symptoms that results from that liver failure and portal hypertension, we could see jaundice, like the person has, their sclera is kind of yellowed, their skin itself is kind of a yellow tone. They might have peripheral edema, and of course the ascites, which is that fluid. I often think of when I see like guys, especially, and they've got like a really hard belly, very large. It almost reminds you of what in if you're 9 months pregnant, how that skin is really stretched over. So that is an indication that they've got some fluid, and they do have that ascites there. Other things that we could see are the skin lesions. We can have endocrine problems, peripheral neuropathies, and then we can actually do some testing where we can look at the liver itself and see the size of it. Are there any nodules on it? Anything like that. So this picture just kind of lumps all of the assessment that you may see, some of the different signs or clinical manifestations of your patient that you can sort of see with them. Um, in the cardiovascular, you've got the fluid retention, um, the ascites, peripheral edema. You can have anemia. They can have coagulation disorders. They can have an enlarged spleen. We can, on the integumentary, of course, you would see the jaundice. They might have petechiae. And then neurologically, we can have hepatic encephalopathy, which is the increased ammonia levels. Therefore, they kind of like confused, disoriented. They'll have the peripheral neuropathy. And then there's a lot of GI factors in here gastritis. We can have dull abdominal pain, nausea, and vomiting, a change in their current bowel habits. And then there's some different things within the reproductive system as well. Testicular atrophy and impotence are two that I would highlight down here in the reproductive area. This picture gives a really good indication of what somebody looks like when they have jaundice. They're just kind of a yellowy skin. Look at that sclera. It's pretty yellow. Um, it, it, the jaundice really does result from that decreased ability um, to excrete the bilirubin. There's an overgrowth of connective tissue in the liver. It compresses those bile ducts so they're not functioning properly. Overall, this will in fact lead to an obstruction, and so you'll have an increase in the bilirubin in the vascular system, which is what causes this yellowing. Uh, it may be minimal, or it potentially could be severe. And then on the skin lesions, they're due to that increased in circulating estrogen due to the inability to the liver to metabolize these steroid hormones. You know, we always have to remember how much our liver uh, handles metabolizing many medications and many of our normal functioning patterns for our body. You might have pulmar erythema. So you might have those. You might have the like spider veinish looking things on the skin that you can see. So these would be some of the assessment data that you would collect as on your patient with cirrhosis. So there's several diagnostic studies that we can use to evaluate the functioning of a liver. There's the liver enzyme tests, and we can look at the AST and the ALT and the GGT. We're looking at total protein, and remember our albumin levels let us know the nutritional status of a patient. We can look at the bilirubin and the globulin levels. We can look at their cholesterol levels because, again, that breakdown that occurs in the liver. We can look at the PT time, and then we can do a fibro scan, which is like an ultrasound. And then, of course, we have the biopsy where we can go in and we can actually pluck out a little piece of the liver. We can send it in for testing, for diagnostics, and help to determine if there's any problems within the liver itself. Some of our clinical manifestations, if we're looking at the hematologic disorders, they can have thrombocytopenia, leukopenia, they can have anemia. And we do know that with our patients that have anemia, we're really going to be able to evaluate some of that, not only in blood tests, but we can also look at the O2 saturation because of um, the RBCs carrying oxygen, then we'll be able to see that there's going to be a decrease in that. There's coagulation disorders, and then we have some endocrine disorders. Again, because of that decreased metabolism of the hormones within the liver. Um, in men, I think I said this in a previous slide, um, the testicular atrophy, impotence, loss of libido. Women, you can have vaginal bleeding. And then in both sexes, you can have the hyperaldosteronism that occurs in both male and female. All right, on additional clinical manifestations, we have the peripheral neuropathy. Um, this is where they have that like pins and needles, and we'll also see this in our diabetic patient, but it's like pins and needles, lots of pain. They lose a little bit of the sensation in their feet. They're not able to necessarily feel their feet. Um, there's sensory and motor symptoms, and sensory symptoms may uh, be prominent. And decompensated cirrhosis, you can have the portal hypertension. Um, Esophageal and gastric varices. So you can have these to where they're bleeding. Literally, they can just start bleeding, and then it's a lot of blood. It can be, it can cause death. Um, they have the peripheral edema. You're going to have the abdominal ascites, the hepatic encephalopathy, and then the hepatorenal syndrome that can also occur. If a patient has cirrhosis, and there's not any complications, this is kind of a good nutritional therapy that we would give them. Their diet would be high in calories, high in carbs, low in the fat, and then protein restricted is rarely needed. Um, but we would look for like protein supplements. I think about things like um, additional shakes, like a protein shake. Uh, People sometimes can go ahead and drink those, and it kind of gives them the nutrients that they need as far as a meal goes. We would want them on a low sodium diet, especially if the patient has ascites and edema, because we know that where salt is, water is, and that's going to cause more of that fluid retention that we would see in the peripheral area of the edema and the ascites through the belly. Um, they don't have a lot of desire to eat, so we can season things. We don't want to use salt, but we do have different seasonings that are available. I always think of like Mrs. Dash. They don't have salt in them, but they do add some flavoring to the foods. Therefore, the patient is encouraged and will eat a little bit more. I would also recommend collaborating with or putting in a consult for a dietitian so that they can meet with the patient. In between the patient and the dietitian and yourself, you can put together a diet that is appealing to them and that they will continue to eat. Because oftentimes these people are very malnourished. Um, they they don't consume a lot of food. I think about like people who are heavy drinkers, like alcoholics, they tend to eat less, but they drink more. And so they don't get nutrients, obviously, from the alcohol that they're drinking. So we need to make sure that we kind of help them to develop a diet so that they do get, um, the what's needed, what the body is needing on a daily basis, as opposed to not eating and causing the weight loss and the lower albumin levels. So our management for these patients, it's really pretty simple. Rest, obviously, they need to, take time to rest and sleep. Um, we might need to give them B complex vitamins. They can be taken orally, or sometimes we do need to give them through an injection. If they are chronic alcohol users, we're going to need to really stress the importance of avoidance of any type of alcohol. Um, sometimes this is easier said than done. If you, as a person, don't have a problem with alcohol usage, it's very easy to say, well, just don't drink anymore. But if people have spent most of their lives and alcohol has been a big piece of it, then it is very difficult for them to stop. And we need to um, give them some tools, some different support groups. There's Alcohol Anonymous, and they can attend AA meetings. We can give them any type of other community groups that might be available to help. So, really, we're going to stress that importance of avoiding alcohol. And we do not want them using any type of aspirins, acetaminophen, any type of NSAIDs, because these can prompt the GI bleed. They have a tendency, as they're being broken down, um, they can cause ulcers, uh, things like that. So we want them to avoid it. Not to mention, it's usually metabolized in the liver, and when you have a liver that's not functioning, we certainly don't want them uh, to use those medications. Complications that we can have is that portal hypertension. It increases that venous pressure within the portal circulation. They can have enlarged spleens. They can have very large collateral veins. And then, of course, we'll go back to the ascites again. The esophageal varices, they are enlarged veins in the lower end of the esophagus. This is very dangerous. The gastric varices and the esophageal varices, uh, they bleed easily. The patient, that's very fragile there, and it is a substantial amount of bleeding, and it can be very life-threatening. People die over this because they bleed out so very quickly because you have to think about how much blood is in there. So, these are some of the complications that we can find with patients with cirrhosis. So, with the ascites, with that accumulation of the fluid, many a times our treatment is sodium restrictions on the patient. We're going to give diuretics so that we can get that excess fluid off. Sometimes we do we remove the fluid itself. Um, and like we do that through like a paracentesis. There's several mechanisms of the complications. We can have the portal hypotension, hypoalbuminemia, and hyperaldosteronism. The hepatic encephalopathy is kind of a big deal. It is because of the neurotoxic effects of ammonia. And so they're not getting like the neurotransmitters are just not working properly. And so you can find that the patient has a change in their neurological or mental responsiveness. They're not making sense. They're confused. They could have the impaired consciousness. Maybe they have some inappropriate behavior, trouble concentrating, and the reason is because the liver is unable to convert the increased anemia. I'm sorry, ammonia into urea, and because ammonia crosses the blood-brain barrier. And this is what is really the reasoning for this neurological change. Most of the time, what we end up giving patients is a medication called lactulose. Patients do not enjoy taking it. It's usually the first line treatment for hepatic encephalopathy. And what occurs is that medication enables the body to grab that additional ammonia, and they will excrete it out in feces. Um, they do not like to drink it. It is not desirable. However, it is a medication that we need to explain to them the benefits of it, and they really need to take it so that we can get the excess ammonia off, and so that we can return back to a more um, coherent neurological or mental state. This is a fabulous picture of ascites. So what do? We can do the paracentesis, where we can pull that excess fluid off. You definitely want to have a patient, if they're having a paracentesis, void before the procedure, just so that the bladder is not enlarged with the potential of maybe nicking it or something like that, puncturing it during the procedure. Again, you would put the patient in a high Fowler's position, And then after the procedure, you definitely want to make sure that you take vital signs and monitor for any signs of hypovolemia or any type of electrolyte imbalances. Because remember, if they've had this fluid volume excess, and now we're going to take it off, we need to make sure that we don't have any problems with fluid volume deficit, that the body is compensating for it. It's one of the reasons why we don't take off a lot of fluid at once. Sometimes they'll do it in several different procedures so as to not shock the body more or less because of so much fluid being taken off. So you're going to monitor the BP and the heart rate. And then after the procedure, you want to make sure that you monitor the dressing for any type of bleeding or leakage that can occur from that. We can also do the TIPS, which is a surgical procedure, and we'll talk about it in just a minute. It is not used very often, um, but there's also a pretty high rate of complications, and that's one of the reasons they try not to use it. But it has been used in the past, and it would be dependent upon the actual patient and if they were a good candidate for it. Some other complications with the hepatic encephalopathy, you can have, again, it's going to be that a lot of neurological. So you can have tremors, like flapping type tremors in the arms and the hands are where it's predominantly at. The patient cannot hold a pen. And then they have this musty, sweet odor of their breath. So if you might be able to detect that if you're near the patient as they're speaking to you. So those are some additional complications that we can find is a renal failure um, that happens because of the hepatic renal syndrome. Um, there's really nothing wrong with the structural abnormality of the kidneys, but because of the liver problems and the hepatic um, portal hypertension, you can get this leads to that vasodilation, which leads to the vasoconstriction, meaning the renal system is not getting what it needs. So the only way that we can treat this particular complication is with a liver transplant. And transplants are one of those things that is just very difficult that people sit on the transplant list for a very long period of time, and it's very difficult to get a transplant. So this is not a good situation because we've had patients that literally um, never make it to a liver transplant. So if your patient has any of the esophageal or gastric varices, we do have some different things that we can do for them. We can give them fresh frozen plasma. We can give them RBCs because of the additional bleeding. We can give them vitamin K. Proton pump inhibitors really do help with the GI system. They help to kind of calm some of that of the lining and kind of support the lining of the stomach. We can give that lactulose, like we had talked about before, to try to get that additional ammonia off. And then we can give them antibiotics for any type of infection or anything like that. Just shows you a couple of the the shunting procedures, and you can see where they put in um, the different shunts so as to try to help with uh, some of the additional problems with the liver. So some of the management, again, back to the hepatic encephalopathy, we want to use the lactulose so we can trap that ammonia and get it out of the body. We can give the some antibiotics, and of course, we want to prevent constipation. So we might need to give stool softeners, things like that. Treatment of the precipitating cause, we might need to go ahead and lower the dietary protein intake at that point in time. We want to 100% control any type of GI bleeding. Um, So if we need to give any type of medication to try to help with that, make sure that we're not giving any type of NSAIDs, Motrin, Advil, Aleve, any of those, which can cause GI bleeding, and then we can remove the blood clot from the GI tract itself. So when you look at our nursing diagnoses and look at health promotion, we want to reduce or eliminate any type of risk factors, treat the alcoholism if that seems to be a problem, maintain that adequate nutrition. If they have any acute hepatitis that occurs, we need to treat that with medications. If they're morbidly obese, um, we can do bariatric surgery for that. Maintenance of food and fluid intake to meet the nutritional needs. We need to maintain skin integrity, and then we want to make sure that we have them and normalize their fluid and electrolyte balance. And again, I go back to the treatment for substance use. So if it's if it's one because of alcoholism, that we need to treat that. But if they have hepatitis C, which has prompted some of this because of previous drug usage, because that is one way that it's contracted, that we need to make sure that we identify that and that we get them the necessary resources and support groups available so that we can help them through kind of kicking that habit of the different substances.